Hey guys, so today we're going to discuss post-operative nausea and vomiting and a risk screening tool that has been employed by this hospital but underutilized thus far. We've done a little bit of research and believe that the reason the tool has not been used is that there's not a complete understanding and appreciation for what it can do to decrease the incidence of post-operative nausea and vomiting. So by definition, postoperative nausea and vomiting is any nausea, retching, or vomiting during the first 24 hours following surgery. Objectives of this teaching is to identify facts that relate to the occurrence of postoperative nausea and vomiting, or what we'll refer to as PONV from this point forward, identify risk factors associated with PONV, identify complications of PONV, 3 pharmacological interventions, and recognize and demonstrate use of this screening tool. On this board here we have a bigger presentation of the risk screening tool that this hospital employs, and we'll talk about the utilization of that in just a bit. So let's talk about facts related to PONV. Of the adult general surgical population, 30% of people will experience PONV. Of those identified as high-risk surgical candidates, 70% will have PONV. Patients will often rate PONV as more troublesome than pain, and if any of you have ever experienced it, you can understand that. As well as increasing institutional burdens, PONV can greatly decrease patient satisfaction and can contribute to such things as wound dehiscence, aspiration pneumonias, all of this resulting in elevated institutional cost. There have been 4 identified risk factors for PONV, and those are the things that you'll see on the screening tool. First and foremost is the female sex. Second, and not often given points correctly, is a non-smoker. They don't quite understand why a non-smoker decreases the incidence of PONV, but it does. Those having a history of PONV are assigned a point, and those anticipated for use with postoperative opioids are assigned a point, for a sum total of 0 to 4. We briefly touched on complications that can occur with PONV, but those again include wound dehiscence, esophageal ruptures, aspiration pneumonias, dehydration, and finally pneumothorax. So let's talk about how the risk screening tool can be utilized. Used preoperatively, in this institution, it's primarily used in the PACE setting, but if a patient has not been paced, it's up to the nurse in the preoperative setting to interview the patient and assign the score. So you tally a score of 0 to 4, and from that final tally, you'll identify a risk factor. 0 to 1 will indicate that a patient has low risk for PONV. A score of 2 will identify a patient at moderate risk, and a score of 2 to 3, and 4 will identify a patient as having high risk. Once the tool has been utilized and a score assigned, the nurse then has a responsibility. The nurse's responsibility in this is that the anesthesia team is aware of it, and that we go after a set of orders from the physician or anesthesia team seeking pharmacological intervention. Some of the interventions used are the scopolamine patch, Zofran IV, and dexamethasone. Zofran and scopolamine are best used preoperatively, and scopolamine even up to 24 hours before surgery takes place. The dexamethasone is used intraoperatively and usually given by the anesthesia provider. In the adult surgical population, does utilizing a simplified risk scoring system compare with not using a simplified risk scoring system affect PONV prior to the final disposition of the patient from the PACU? This was the PICO question assigned to this capstone. And we feel that it has been adequately answered, and that the pharmacological intervention can and does in fact contribute to decreasing incidence of PONV. In conclusion, PONV has shown to have detrimental effects on both patient satisfaction, outcome, as well as institutional burdens. Through the use of a simple risk scoring system, we can decrease the incidence of PONV, elevate patient satisfaction, and decrease institutional cost burdens. So I hope that you, through this presentation, will understand this risk scoring system a little bit better, and the nurse's role in making certain that this is utilized and that the anesthesia provider has orders in place prior to that patient going to surgery. From the handouts that I've given you, I would like you to take the quiz, and that will be tallied and assessed again for need for remedial instruction, as well as an evaluation for this presentation. Thank you for your time.